Hello, everyone, and thank you for joining us for our Innovation Showcase hosted by Taewoong Medical USA. I'm happy to introduce Shirley Wang with Taewoong, who is going to get us started. Shirley, I will turn it over to you.
Thank you, Lauren. Hello, everyone. Welcome to our Innovation Showcase. My name is Shirley Wang. I am with Marketing at Taewoong Medical USA. We are honored today to have Dr. Imad Kandil here to present a thyroid RFA case discussion. So for today's agenda, I'm first going to go over some innovative features of our Viva Combo RF system. And then Dr. Kandil will present an interesting case with us. There will be time for Q&A at the end, so please use the Q&A function at the bottom of your screen to submit any questions you may have about the procedure or our devices. So without further ado, let's jump right in. StarMed RFA system has the longest history on the market in the treatment of thyroid lesions. It has been helping patients around the globe for over 15 years. And Taewoong Medical USA is the exclusive distributor for StarMed Thyroid RFA system. The Viva Combo RF generator is suitable for either monopolar or bipolar applications. It comes with a continuous power output mode and a real-time impedance monitoring system dedicated for thyroid ablations. Safety has always been at the heart of our innovations. Our generator comes with an automatic shut-off safety control and a Viva pump cooling system to minimize tissue charring. Our Star RF electrode is the first electrode on the market designed for thyroid nodules. It is also the electrode with the longest history in treating superficial lesions in the thyroid gland. Our sharp tip technology has been praised by many physicians as it enables smooth tissue puncturability without the need of a scalpel or an incision. We're currently the only company on the market that offers a range of electrode sizes to accommodate a variety of thyroid indications. We offer 2 gauge sizes, 18 and 19, and 3 shaft lengths, 7, 8, and 10 centimeters. We also offer 4 active tip length selections, 4, 5, 7, and 10 millimeters to target a range of neck indications from small structures like lymph nodes, parathyroid, to large thyroid nodules. Currently, the 4 millimeter active tip size is the smallest tip offered on the market. To facilitate our physicians on board, we launched a comprehensive thyroid RFA training program with our partner physicians in 2019. And since then, we have trained over 100 physicians, and they came back with great feedback. For more details, you can visit taewoongacademy.com. Dr. Imad Kandil is a professor of surgery and the chief of general, endocrine, and oncological surgery at Tulane University Medical School. Dr. Kandil is the first physician in the USA to perform over 150 cases on thyroid RFA. Please welcome Dr. Kandil.
Thank you, Sherry, for the introduction. I'm honored to be with all my colleagues here in the ES, and we're going to go through first a case that I would like to share. My favorite patient to offer the radiofrequency ablation for are patients with hyperactive nodule. And this is here a patient here where we can see a hypervascular nodule in the left thyroid lobe. And you can see the images. So I like to go actually with the short axis technique, and you can see here I start from lateral to the middle to medial. My preferred tip size probe is a 7 millimeter, but depending on the size, you decide on the energy level too. So if I'm using a 7 millimeter tip size, I will use 25 watts for energy. If I'm using a small lesion, then I will use 15 for the 5 millimeter and 35 watts for the 1 centimeter if you are trying to ablate a huge nodule. You can see the bubbling, which is an effect of the ablation, but you also need to focus more on the impedance, and you try to get the impedance to approximately 200 ohms to get an appropriate ablation of the nodule. During the procedure, I talk to the patient. The patient is fully awake, and try to make sure that the voice is good, and we try to stay away from the dangerous triangle by the entrance of the nerve medial to the trachea. So with this, we'll go with the presentation. I'm going to try to go through a few slides sharing my experience with the procedure, and we'll take it from there. So in my practice, every single patient gets an ultrasound exam. Ultrasound is part of the physical exam. In my practice, I do have 2 rooms for ultrasound exam. So it's something that I think if you want to do this, has to be very comfortable with the procedure and with the biopsies. And I also ultrasound everybody in the OR. And I think even if you do not have this available in the clinic, you need to try to make sure you're comfortable with the anatomy and the procedure. But I think most of us do biopsies, so adopting this technology should be really something very easy for us as surgeons. There is significant data on the ethanol ablation for cystic thyroid nodules, and I was a big fan of this, and I had a couple of publications on the field, but as we know, the ethanol ablation was a little bit disappointing with solid nodules. I published before a meta-analysis looking at percutaneous ethanol ablation versus reoperation for locally recurrent papillary thyroid cancer. And basically the conclusion that reoperation was associated with the 3.5% pooled risk of complications compared to significantly lower risk of complications with ethanol ablation. This is a slide from the Italian experience, looking at 6 institutions from Italy with almost 400 patients. And the take-home message here that you expect the shrinkage in the nodule for the volume reduction rate to continue with time to maximize a 6 month, but then start to plateau approximately a year after the ablation. This is here a table with the possible complications related to the procedure from this large experience from 6 institutions. And as you can see, in general, the risk of complications is extremely low. The recurrent laryngeal nerve injury is well below 1%. In my own experience, I'm almost near 200 cases so far. I had 1 patient who had vocal cord paresis, and it took a couple of months for a recovery from the ablation, from the thermal injury to the recurrent laryngeal nerve, but it was completely recovered. This is here to show we have a paper that's under review right now where we combined our early experience with the Hopkins experience, and we actually compared it to our prior experience with ethanol ablation. And you can see that the volume reduction rate was an average 41% in the radiofrequency ablation compared to 22% in the ethanol group. This was at 6-month period. Our rate of volume reduction rate significantly improved with time to be near 60% with experience. This is here an experience with my first 100 benign thyroid nodules with time, and you can see it start to plateau again after around the 6-month period. But on average, we had over 50% volume reduction rate. We have patients that had a reduction rate of over 90%, and patients are extremely happy with this. Mostly patients with large nodules, compressive symptoms are the patient who really appreciate it because the symptoms are away and you can see the visual appearance. I do have the option of doing elastography on thyroid nodules, and I published this related to ethanol. It's well known that increased internal vascularity is a risk factor for resistance to treatment by radiofrequency ablation. So I looked into elasticity and vascularity. And as you can see here, vascularity did affect the volume reduction rate, but if you do have a stiff nodule and high vascularity, the volume reduction rate will be the lowest, will be somewhere between 30% compared to near 80% of the nodule is a soft nodule without an internal vascularity. My favorite patient for this approach are the patients with hyperactive nodule. This was one of my first patients that I treated with radiofrequency ablation. Was 84-year-old gentleman from Florida. I was trying to speak to my referring physician about this. So this patient has been walking around with uncontrolled hyperthyroidism with this hyperactive nodule and maximized dose of antithyroid medications. And after just a 1 minute treatment with the radiofrequency ablation, you can see here the volume reduction rate approximately 3 months after the treatment was near 70%. But the most importantly, his TSH was 14 when we checked it at his post-op visit. So basically, he was cured from this disease. It's interesting to know that there is no effect on thyroid function test by radiofrequency ablation or any other ablation techniques. The risk of hypothyroidism is well below 1%. I did not see in my experience so far any patient who had really hypothyroidism, but also this is what the data show in the literature. So there is a published meta-analysis on radiofrequency ablation on hyperfunctional nodule. And this is here the table of the studies that were included, approximately 7 studies. And basically what they showed that the volume reduction rate can be up to 86%. And the cure rate is approximately 75%. You can see here also that they published the data on the scintigraphic proven recovery of the function in 60% and different numbers, but it's not 100%, but like a good percentage of these patients, 3/4 of these patients will be cured with the radiofrequency ablation. A recurrence is an issue. So what I did try to review that. This was an old paper a few years ago. So I tried now to look at radiofrequency ablation versus the ethanol versus what published in laser ablation recently on the hyperfunctional nodule. And this is here, you can see 12 articles for radiofrequency ablation, 11 for ethanol, and 4 articles for laser ablation. And we identified 3 additional articles compared to what was published in the prior meta-analysis on the radiofrequency ablation for hyperfunctional nodule. And sorry, the slides are just not moving. I'm trying to control this remotely. And here's the table that includes the approximately 12 studies with ethanol ablation and 4 studies, as I mentioned, 3 of them from Italy on the laser ablation for hyperactive nodules. So what we found that we looked at the failure rate and the complication rate. The failure rate was significantly lower in radiofrequency group, 3.5% compared to 16% approximately in the ethanol group compared to 13% in the laser group. And the complication rate was also lower, but was not statistically significant. It was 5.8 for the radiofrequency compared to maybe 1/4 of the cases on the ethanol and the laser ablation. So that's it. So I really think it's a technique that's can be a good alternative for patients with benign thyroid nodules. There is published data now, multiple recent publications. I did not want to go through this for small, well-differentiated papillary cancer, and also for patients who are high-risk thyroid cancer who are not a good candidate for an operation. And the results are really impressive. I think really this is the future. I think endocrine surgeons are the best one really prepared to do these operations. I think endocrinologists might be uncomfortable using these big, huge needles in the thyroid, worried about hematoma, worried about the recurrent laryngeal nerve. We do have access to these patients, and I think we can help these patients very well with this really minimally invasive option. Thank you.
Do we have any questions from the audience?
Dr. Kendall, excellent presentations. This is Minsu from Taewoong Medical. So do you think you can share with us your learning curves? I know that you did already close to 200, and then there's a lot of physicians from the US, they are about to start, and they're always curious about what's the learning curves and what else they need to do practice before actual procedures. So can you share your experience?
Yeah, absolutely. Well, thank you very much for the question. But let me really say this. So I was trained by different companies related to this approach. And I have to highlight that I had really an excellent experience with Taewoong. Like, not in a single case, I did not have the rep available to make sure that everything is prepared well and things are ready to and done right. So, as I said, if the surgeon is trained to do biopsies very well, this procedure should not take significant time. I think we can do these cases like really from the patient entering the room to leaving the wheels in and out under 20 minutes. The procedure itself, once they do the timeout, is almost all the time under 10 minutes, and it can be even less with a smaller nodule. You only spend longer time with a significantly large nodule, like a 9-centimeter nodules and stuff like this. I learned from experience after the one complication that I had with the recurrent laryngeal nerve that was temporary, that maybe less is better. So what does that mean? I felt that I'm with experience, I'm burning more, I'm seeing more volume reduction rate on the first 30 days after the ablation. So usually I see patient 1 month, 3 months, 6 months, and then a year after the ablation. So I started to burn more. But when I had that like complication, this patient, by the way, had maybe 91% volume reduction rate. But I learned maybe I'll burn less and I will have less complication. So this is really a lesson that I started to do a little less, and specifically less towards the dangerous triangle. But it's very easy for endocrine surgeons who really like comfortable with the procedure to do this procedure. I see here a question from Dr. Howe about how does this probe differ from liver probes? Does this have times? Do you see the whole lesion? So I do not have experience with the liver, Dr. Howe, with the liver probe. I think maybe I'll leave this to Mansu, but I look, as I said, for the bubbling effect, and also I'm monitoring for the impedance. And for me, I will have the rep keep saying the numbers loud. You can actually look at it, but I want to keep my eye focused on the lesion the entire time. And the rep will keep like mentioning the numbers, and I move the probe up as once I get an impedance of 200. I don't know if Mansu, you want to comment how different is this probe from the liver probe?
Yeah, absolutely. So we actually, the first case, we did it over 20 years ago. We're using a liver device, like a liver ablation devices, because that time there's no device designed for the thyroid. So, had to using it, but obviously there's a limitations on the size. And then because of the, little bigger size, bigger ablations, we couldn't ablate as much we can. So we changed all the design of the probe, but the concept will be very, very similar. But the needle itself is very small, and the 18 gauge and 19 gauge and ablation zone will be much smaller, that you can exactly targeting to the small nodules and ablating it. So that will be the biggest difference between liver device versus thyroid device.
Yeah, thank you. So I have here multiple questions. I see Dr. Peter Andrews asking me a question about the medial approach, the transisthmic approach versus the short axis approach that I use. So Dr. Andrews, I used to do the transisthmic when I started, but it's a little bit troublesome for me. And I honestly think, let's say that this is the lesion. I don't see any difference between coming from the medial approach versus coming this approach. If this is the lesion, I start from the lateral side and I keep going to the middle until I keep the medial part, which is the most dangerous part, to the end. I'm a believer that this is enough and this is perfect. My results speaks to itself. Anyone is welcome to come and watch. You have a lesion, you can burn it that way or that way. Make sure you stay away from the dangerous triangle. And I have extreme respect to all my colleagues who insist that this should be done with a transesmic approach. I don't see why you need to do it that way versus the standard short axis approach. I intend to do a study comparing both approaches. At least in my experience, the transesmic will take definitely longer time, but I feel much better control with the short axis. I can see my needle all the time, the tip of the needle. I'm very comfortable with the technique. It just is very natural. I can do this like literally backhanded. Anyone who does biopsies can do this very easily. This is my personal opinion, but I plan to do a study to prove that. There was, yeah, somebody asked about the second time for need for another ablation. So as I mentioned earlier in my experience, that I learned to do a little less to avoid the possible complication. And I tell this to patients, you know, I make sure that you are happy with maybe less reduction versus having vocal cord paralysis. You know, from different meetings, I've seen different people doing like a staged approach. For a large nodule, they do the upper part and the middle part and the lower part, and they can maybe do 3 sessions separated by different times, by maybe a few weeks or so, a week. I don't see a reason for this, but definitely the data show that you can have a recurrence and you can have a resistance. As I said, on average, they start to plateau after 6 months. Definitely they can keep going up to a year, but definitely after a year they plateau. But you can have some resistance with extremely vascular nodules, and you might want to try again. I did have to take patients back for another ablation when they had like a big, huge nodule shrunk, maybe 50% or so, and start to grow again because it's very vascular. The patient is not interested in surgery. They are interested in this approach to shrink it. They were happy with just the shrinkage without an operation. So I did have a couple of patients that required take back. I've been doing this for over 2 years now, so it could happen. Regarding the insurance, yes, I mean, it's an issue for reimbursement and for coverage. Really, the reimbursement went down since we started. And I'm not going to talk about numbers here. I'm in academia. I care about really the outcome more than anything at this point. But I think it's all, we don't have a code, but at some point we are working through different societies with our colleagues in New York to try to eventually have more published data and codes, like a CPT codes for the procedure. Which will happen eventually, but I can tell you, I take a little extra effort. I try to get on the phone, speak to the insurance companies, and write letters. And I'm happy to share some of these letters with any of you. Just basically saying, well, listen, if this patient is not undergoing this procedure, they will undergo surgery, which is more expensive. And in some cases, in the same day, the thing gets really approved, but it will need maybe some effort. I'm going through. So there's a question about, did you operate on a patient after an ablation? Yes, I did. So there's a patient that I thought I can treat with it was a huge, large hyperactive nodule, and did not respond to the ablation. I took the patient for surgery, and there's definitely a lot of scar tissue and adhesions. So I don't have extensive experience, but when I talked to my colleagues in Korea who had experience operating with these patients after they said they prefer to wait longer time, and maybe 6 months is the number that was recommended to me. I did not wait that much. The patient was like needed an operation, so I had to do it, I guess, within 2 to 3 months. And definitely there was significant, a little bit more scarring, but it was not like, it didn't add significant, I mean, hyperactive nodules are hyperactive nodules, but it does make some difference, at least in that case that I did. So if you can see from the video, somebody asked about how does it look? Can you differentiate? Difficult to monitor for possible malignancy. I mean, if you try to look at the nodule after the ablation, you're not going to see anything because of the effect of the bubbling. But like when I see him a month after, you actually see a nodule. You can see the nodule, so it's not an issue, and you can always consider rebiopsy if the nodules start to grow, etc. A question about the biopsy at the same time. Ideally, the recommendation by the Korean guidelines is to have 2 prior biopsies that prove that this is a benign nodule. So this is the current recommendation. But in my practice, I routinely, with every single ablation, I do another biopsy to make another extra step of safety to make sure we're not missing anything.
Dr. Ken, there was questions for the
Dr.
rupture.
Dr. Koo said that she's still trying to support the transismic approach. I respect all my colleagues. It's okay, but I don't think there's any study that compared both, and I never came across one study that compared both. I plan to do one. I would happy to compare with other institutions, but I'll take it from there. Rupture. I don't have any experience with rupture, or I did not see any of this. I mean, you can think, obviously, if you rupture a thyroid, you can seed the thyroid. To my knowledge, there are no published report of such complication of rupturing or seeding thyroid tissue on the track. Did I cover all the questions? Listen, I think this is really, as I said earlier, it's a technology that as endocrine surgeons, we should take a lead for. With all respect to all our colleagues in other specialties, we are the one who eventually will need to consider operation versus this, and we should have this option in our maternity, like to offer to our patients. We're still having a problem right now with the CPT code. But I think this should be eventually resolved in the near future. I think most surgeons across the country who have been doing this on continuously, they are doing very well. The patients are happy. Dr. Jennifer Koo has a great experience in New York, and John Russell and Ralph Tofano at Hopkins. And many others, but it's something that if you start doing it, you see the difference in your practice and your patients, and you see the appreciation of your patient. And I just think we just need to figure out how to learn it and teach our fellows how to do it, because this is here to stay.
Thank you, Dr. Kendall, for your great presentation, and thank you so much for your case discussion. Thank you everyone in the audience for your participation and visiting our Innovation Showcase today. We hope you find our event informative, and we look forward to seeing you all very soon. At this time, I'd like to officially close this event. Enjoy the rest of your day at the conference. Thank you. Bye.